Allergies are one of the toughest cases I see in the clinic.
Up to 25% people who come into clinics and hospitals saying they have food allergies, when we do something called a challenge test with them, only 3 or 4% of them actually have an allergy.
People come in with this huge bunch of papers and they've done this IgG test in which all the foods are color coded, and the client comes back saying that I see red on wheat, I see red on milk, so I've already started avoiding them.
IgG test is never considered to be a food allergy test by any allergist worth his mettle anywhere in the world. Infant or toddler who has a cow's milk allergy, the chance that that child won't have the milk allergy when they are 6 or 7 or 8 years old is up to 90% that they would have outgrown it. If you take an egg allergy, again the chance of outgrowing it is up to 80% by the age of 6, 8, 10, 12 years. Pregnant mothers, they used to be told to avoid allergenic foods during pregnancy.
Right.
But very good research has been done on this in different parts of the world, and you don't need to do that.
And is infant colic related to food allergies?
The cow's milk protein allergy can do to infantile colic. It's very, very tiny.
Okay.
But it is relevant. Now we realize that avoiding actually increases their chance of developing allergies when we try to introduce it later.
Hey everyone, this is Shwetha Bhatia. I'm a board certified dietitian and sports nutritionist. Allergies are one of the toughest cases I see in the clinic. If allergies, and particularly food allergies, have been bothering you, then this episode will give you some clarity. Today I'm joined by Dr. Sitesh Roy, a US board certified allergist and immunologist. He is one of India's leading consultants with 25 years of experience in the field. His clinic, by the name Dr. Roy's Health Solutions, is in Mumbai. He is here today to help us navigate through the complex world of allergies. We'll be discussing everything from the common symptoms to the unusual ones, how you can diagnose and manage food allergies with the relevant tests and treatment. So let's dive in. Welcome to my podcast, Dr. Roy.
Thank you for having me.
So, at the outset, before we start this conversation, I really want you to clarify the differences between food allergies and food intolerances, because I think there's a lot of confusion amongst people as to whether they're allergic to something or they're just not tolerating a specific food. So can you tell us a little bit about that?
Sure. So you bring up a very important topic and something that we all deal with on a daily basis. Me as a clinician, you as a nutritionist. I think the word food allergy is very loosely used these days. When we look at the categorization of these reactions to foods, if I may call it, we now call them food hypersensitivities.
Right.
That's the more appropriate term. And within that, if you have an immunological reaction that is mediated by something called an IgE molecule, it's an antibody that we all have. It's historically been there to help us fight parasites, viruses, many infections. But when it gets formed against a food, it can cause a lot of havoc inside the human body.
Right.
So that's a very classic IgE mediated food allergy. And very good studies have shown that up to 25% people who come into clinics and hospitals saying they have food allergies, when we do something called a challenge test with them, only 3 or 4% of them actually have an allergy. So who are these other people? These are the other people who think they have a food allergy, but they actually have a food intolerance,
Right.
which can be a non-immunologic reaction. The classic example is like someone drinking milk and getting gas, bloating, indigestion, diarrhea. They
Right.
think they have a milk allergy, when in reality what they have is a lactose intolerance. Similarly, some people having fruits and fruit juices can have a fructose intolerance.
Right.
A person drinking alcohol and getting all flushed and red and nauseated and throwing up, they can have an alcohol intolerance. So the list is very, very long.
Right.
And these are not immunologic reactions. Generally, intolerances are not life-threatening. They are life-altering. They can really affect a person's quality of life. But food allergies, the classic food allergies, they can be serious, they can be life-threatening, and they can be very, very dangerous if not diagnosed and if the foods are not eliminated. And there's a lot more to this. So there are non-IgE mediated immunologic reactions, which again get clubbed in as food allergies, but they're actually food hypersensitivities. And I think it's a complex field in which they really need, I think individuals need help as to seeing a specialist, seeing a consultant, seeing a nutritionist to guide them.
Very beautifully explained. In short, I would say that if you truly have a food allergy, then it's going to really announce and come.
Correct. And even small quantities of it can give you hives, which are red rashes on the body, itchy
Right.
ones, swelling, difficulty breathing. You can have low blood pressure, pass out, faint, have nausea, vomiting. It can go all the way to anaphylaxis, which is life-threatening. And it always happens. There are people who will come and say that when I eat this, I get a reaction. That we ask them, do you eat it at other times? And they say, yes, we eat it all the time, but nothing happens. So a food allergy would never do that. You would get a reaction every time you consume it. It may be milder when you eat less and severe when you eat more, but you're going to see a reaction. Whereas intolerances can be different. They can be dose dependent, depending on how much enzyme you have to digest that food, for example. So tricky field, but difficult for a layperson to really interpret on their own, as I may say it.
I remember that one case which I referred to you of the anaphylaxis. And yes, as you rightly said, it's so tricky for even people like us who are educated about the topic, but we still, we go scratching our head sometimes when we have a patient come to us with these cases.
Absolutely. So it's like you rightly said, it's all history,
Right.
followed by the right investigations, and we can really narrow it down whether this is a true food allergy or a classic IgE mediated food allergy,
Right.
or it's a food intolerance, or it's a non-IgE mediated food hypersensitivity. There's just a lot going on.
It's best left to the doctor, that's what I always say. So my next question is about the lab tests. Whenever I'm taking history, I see that people come in with this huge bunch of papers, and without anybody having told them to do the test, they go to the labs, and most of the times the labs offer them as part of the package. And they've done this IgG test in which all the foods are color coded, and the client comes back saying that, I see red on wheat, I see red on milk, so I've already started avoiding them. And I'm like, why did you do the test? Do you know the relevance of this test? So very, very important, before people go and run into labs and just get tests done and conclude that they are intolerant or allergic to a certain food, are these tests valid? Are they relevant? Should someone do it without a doctor's advice?
So you bring up again a very important point, because we too see this all the time, where a patient or an individual walks into a lab, says that I think I have allergies, and the lab tells them we have these panels that you can do. And many a times the lab technician or the person at the front desk in the lab does not know the difference between an IgE molecule and an IgG molecule, because IgE is your classic hypersensitivity allergy,
Right.
whereas IgG, interestingly, is what we call the tolerance antibody. So from the time we drink our first sip of either mother's milk or a formula, a body has a choice whether to make a hypersensitivity response to that milk protein, which would be by IgE, or make a tolerant response to that milk protein through IgG. So IgG is supposed to be present in every live human being. It's our natural human response. And hence the IgG test is never considered to be a food allergy test by any allergist worth his mettle anywhere in the world. Okay? Whereas I see people who spend 5, 10, 15, 20,000 rupees doing an IgG food intolerance test and telling me I'm allergic to all these foods. And I have to spend the first 5 minutes explaining to them the difference between a food allergy and a potential food intolerance, which again, even the American Academy of Allergy, Asthma, Immunology says that IgG tests are not reliable because, one, they don't detect food allergies. Second, if someone has very high IgG, then they could potentially have what is called immune complex reactions to those foods, but that only needs to be evaluated by a clinician who understands the test. The reason being, the manifestation of an IgG, a food IgG reaction, is again very non-specific, like maybe nausea, abdominal pain, diarrhea, gas, cramping, bloating, headaches, body ache, fatigue, which is not your classic food allergy response, where you're seeing more of the itching, hives, rashes, difficulty breathing, sneezing, watering eyes, vomiting, diarrhea, drop in blood pressure, like I said, and
Right.
other features. So
Right.
I think that the idea of individuals going directly to the lab and doing a test is a very bad idea. You really need a clinician or someone, again, who understands the difference to decide whether you need an IgE mediated response test, which is called a specific IgE test, or there's something called CRD, or whether you need the the food intolerance test, which, again, as I said, most allergists do not order, but there are specific situations in which it can be relevant, and I do utilize it very, very selectively in my practice. But yes, there are a lot of people wasting a lot of money doing these, walking into a lab and asking for a test. It has to be based on the person's history.
Right.
As I said, it's all history, 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 and then the test.
Right.
Test does not come first and then go around finding who can help me with what I turned positive to.
So what I understand is that the IgG test has some relevance when it's a mixed type or it's indicating towards a food allergy, like you mentioned, the immune complex reactions. But one must do it only after a physician has recommended to do those tests. And it
Absolutely.
has to be also interpreted in the clinic by the physician. Otherwise, it just simply means a regular test would just simply mean that you have been exposed to that food.
Absolutely.
And there may not be any reaction, so there's no requirement to stop eating that food.
Correct. And that's the concern. People stop multiple foods and come to us.
And also that makes the testing of the actual allergy a little complicated. Am I right about that as well?
So you're absolutely right. It does create some hassles in terms of how we now get the history from the patient, because the patient has seen a report. They assume that they have a hypersensitivity, whether it's an allergy or an intolerance to it, and they are avoiding it. And now they start seeing symptoms where there were none, because there's an immense psychological impact on food allergies or food reactions, not
Right.
food allergies really. However, that internal bias that they have, which jades them and makes them think that if I eat this, I get this problem, now is a whole new level that we have to deal with. And we even have to go to the extent of doing sometimes what we call double-blind, placebo-controlled food trial challenges to show them that no, that food is not causing a problem. So I think absolutely it creates several layers of issues when someone has already done a test and come to us, and a test that wasn't relevant or has picked up what we call false positives, because just a positive test is not an allergy, or just a positive test is not an intolerance. There has to be a clinical correlation with that test, and only then would we really call it to be an allergy.
But it's also, is it possible that once they start avoiding the food, if they were really allergic to that food, then the specific IgE test would also not be accurate?
In terms of repeating a different test where we do specific IgE or we do a skin test, that does not get affected if they have avoided the food.
Okay.
We're still able to get a clear picture because these are long-term memory immune reactions. They don't get altered just by avoidance for a few weeks or few months. We have people who have a very low positive specific IgE to a food who can have anaphylaxis and be in an ICU. And we have people with very high specific IgE who are eating the food on a regular basis and having no symptoms. So the test itself does not tell you whether the person is allergic or not. It just tells you whether they are sensitized or not.
So either ways, whether it's the IgE or the IgG, both of them, just having them, come positive on a test doesn't really give us any indication.
Absolutely
it has to be
not.
interpreted correctly by a clinician who understands the process.
Absolutely. Perfectly put.
So speaking of tests, can you tell us a little bit about, all the different kinds of tests that are indicated in diagnosing food allergies specifically? We're not talking about intolerance here. What are those tests? Can you tell us a little bit about them?
So when we talk about allergy testing, based on the history that we have received of the individual, the commonest and most accepted test, which has been there for the longest time, is something called an allergy skin test. It's also called a skin prick test. There's an older way of doing it, which was called a scratch test. In these tests, we introduce a very tiny amount of the allergen into a person's skin, very superficial layers of the skin, not deep inside. So there's no bleeding involved, there's no risk of any major reactions really that I could see if it's done correctly. And through this skin test, within a 20-minute span, we can know whether a person has an allergy or not because there's something called a wheel and flare. Think of it like a hive, like a mosquito bite reaction can get quite big at times, which we then measure and we compare it to a negative and a positive control. So it's a very, very efficient test, believed to be the most clinically relevant because we are measuring the IgE, the allergic antibody that is bound to the mast cells, which are the ones that release histamine and give us the allergic symptoms along with other mediators. The second test that's available, which has become very popular in the last maybe 15, 20 years, is something called a specific IgE test, also called an immunocap test. There are other systems of doing it. And in this test, we are measuring the IgE level in blood.
Okay.
Here we are measuring free-floating IgE. So this is not bound to mast cells and basophils and other types of cells. So there is a slightly higher chance of picking up what we call false positives or background noise if someone has a very high total IgE level. So we have to interpret them with a little bit more care, as I would say. But the good part about it is it can be done without having to stop any anti-allergic medications, which can interfere with the allergy skin testing. If someone can't stop them, we have to stop them only for 48, 72 or a few days at a time so we can do the skin testing. The next test that is available is something called a CRD, a component resolved diagnostics. It's also called molecular allergology. It's the latest form of testing where we can actually get the subcomponents of an allergen. So let's say I get a small child who has a milk allergy or one with an egg allergy. And the questions that the parents have, one, is the child really allergic, which even the specific IgE test can tell me. But in a CRD, I can actually get the breakdown components of which sub-proteins of milk or egg that child is allergic to. And based on that, we now have data to know whether that child could outgrow that allergy in the future, or this is going to be a more of a long-term allergy or a high-risk allergy with risk of severe reactions. So CRD has its advantages over specific IgE. Specific IgE has certain advantage over skin test, but skin test is still the most clinically relevant and believed to be what I would call the gold standard. Now, many a times we do both two tests. We do the skin test and the blood test because there is always a small chance of error in a test, maybe 2%, 3%, 1%, 5%, depending on what we are testing. So sometimes we do both type of testing, but in a selective and informed manner so that we don't miss any of these allergies, especially in people who are really suffering with bad allergies, reactions, bad atopic dermatitis or eczema. Food allergies can be relevant sometimes there. So it becomes very important to look at that and which test we do. Beyond this come the challenges, which is the gold standard. So you give someone a food and they start breaking out in hives or their lips and eyes swell up or they start having trouble breathing. We don't let it go to that level because we do it in a graded format where we start with a very tiny dose and then we gradually escalate the dose over a span of time, and within a couple of hours we complete that in a well monitored, careful manner. And if they have a severe reaction or an early type of reaction, we treat it and we stop the challenge, and then we label the person to be allergic to that food. And that's supposed to be the gold standard of testing when you actually do an oral food challenge.
So you mentioned about stopping medications before the test. I just wanted some clarity on whether the patient should stop the medication or your clinic guides them as to what to do. Or for example, if someone's just started taking the medications before they came into test, would that affect the test result?
So certainly certain medications can interfere with the allergy skin testing. The blood tests for the most part are not affected by any of the anti-allergic medications which are called antihistamines that a person might be taking. But if someone is, let's say, got nasal allergies along with their regular food allergies, or they're having hives or urticaria and they're taking antihistamines every day, then it becomes a challenge to do the skin test because the skin test reaction can be suppressed by these antihistamines. And depending on the type of antihistamine, so if it's a old, what we call first generation sedating antihistamine, then those have to be stopped for at least 48 hours before the testing. And if we are dealing with the second generation antihistamine, the non-drowsy ones, There's something called cetirizine, there's something called fexofenadine, there's something called belastin. Those have to be stopped for sometimes up to 5 days before we can get a very clear and accurate test. And hence, on every single patient, what we do in our practice and what is standard of care is to do the positive and negative control. If a person has antihistamines in their system, the positive control will also come negative, or it will come very subdued, and then we know that we can't do the allergy skin testing for that person. We do give instructions to the patient when they call our clinic. We ask them a brief history and suggest to them that if they would need an allergy test, they need to stop these medications. But sometimes if they are unable to stop it because of the severity of their disease, then these are the cases where actually deferring to a blood test becomes more sensible, because you don't want to interrupt the treatment and the control of that patient in that situation. The other drug that we commonly get asked about is steroids. So short courses of oral steroids also won't interfere with the allergy skin testing, but if they are on it for weeks or months together, it may sometimes interfere with the degree of reaction. Those are very few cases in general. And if someone is applying steroids to the skin, we tell them to stop doing that several days before we place the skin test on that area. So if it is applied to an area where we are not applying the skin test allergens, then they are okay with using steroids in other areas as a cream or a lotion. But if they are going to do it on the area where we are doing testing, it will interfere with the test. So we have to stop that.
So, Dr. Roy, can you tell us about whether allergies really resolve? And, for example, in kids, if they develop it, would they have to live with it? And what about adults? Like if they've developed an allergy suddenly, once they've become adults, then what happens in those cases?
So I think this is a question that is at the top of the mind of a lot of parents and adults when they come to us and we actually confirm they are allergic to a certain food, whether it's a child, a teenager, or an adult. And there is very good data about this that we have with decades of research. So if you take a small infant or toddler who has a cow's milk allergy, the chance that that child won't have the milk allergy when they are 6 or 7 or 8 years old is up to 90%, that they would have outgrown it. Okay. If you take an egg allergy, again, the chance of outgrowing it is up to 80% by the age of 6, 8, 10, 12 years. However, when we look at allergies like peanuts and tree nuts, the outgrowing rate for peanut allergy is about 30%, 40% at best when we are talking of kids who are growing up. And when we talk about tree nuts or seafood, especially shellfish, that number goes down even further to 5, 10% or 20% at best of someone outgrowing those kind of food allergies. It also depends on the severity of the allergy, the kind of reaction they had in the beginning. So if all they had was a little itching in the mouth and a few rashes, then their chance of outgrowing it is higher than if they got a full-blown anaphylactic reaction where they were having swelling up, having trouble breathing, or ending up in the emergency room or something with it. There are ways to predict this, as I said, the specific IgE level initially, and then later the CRD testing that we have now can help us actually, you can say, prognosticate or kind of predict whether this child can outgrow an allergy or not. And there's obviously the ability to do something called oral food desensitization or tolerization in these cases. When we talk of adults with food allergies, it's a different story. Let's talk about it in two ways. One, if a child has grown up to be an adult with a food allergy and they've already had it for 15, 20, 30 years, chances are they're going to have it for the rest of their life. Okay? Very unlikely they'll outgrow it. If an adult developed a new onset food allergy, depending on which food again, so the common ones that adults get allergic to are nuts and seafood, including fish and shellfish. Fish allergies sometimes can be outgrown. When we look at the kid data, even up to 30-40% outgrow, but shellfish is very uncommon. So if we see an adult with a nut allergy or a seafood allergy, we really tell them to avoid it for the rest of their lives, because the chance of outgrowing is very low, and the data with desensitization with adults is also not that great. It's almost like the immune system is more flexible when you're a infant, toddler, or young child or teenager, and it becomes set in its way when you're an adult and doesn't really change that much despite what we do. And there are some treatments available to make the reactions less severe or less life-threatening in these cases that are available now. But sometimes people do have to live it for the rest of their lives.
So, we're coming to a very important part of this conversation, and something which even I need to know, because we have a lot of cases of pregnancy and lactation. And I want to understand whether there is a requirement for pregnant women to avoid the typical allergenic foods. And I'll also come to the part about weaning kids off early on foods which are allergenic. But can you tell us a little bit about what pregnant women, what caution they should observe, if at all they need to observe, to ensure that they're not going into allergenic reactions or passing something on to the baby during pregnancy?
You bring up again a very, very important point, something that we get asked a lot, even when I'm doing lectures to pediatricians groups and also by parents. Previously, there was this concept that pregnant mothers, especially if they had a high risk of a child being born with allergies to them, like they had a first child who has severe food allergies or severe atopic dermatitis, they used to be told to avoid allergenic foods during pregnancy.
Right.
But very good research has been done on this in different parts of the world, and what has been found is that you don't need to do that. You cannot pass on an allergy to a newborn just by eating a food during pregnancy.
Right.
So this entire concept has now been erased out, and you can't reduce the risk of that child becoming allergic by just avoiding those foods. So mothers are told that whatever their natural, routine, healthy diet is, to follow that throughout the pregnancy. And if the child is at high risk, we will talk about the weaning of part when they start breastfeeding and what happens after that. And even during lactation, if the baby or the infant has been found to have a food allergy, confirmed,
Right.
only then the mother may be told, if she's breastfeeding, to avoid that food in her diet.
Right.
Because small quantities, what we call traces of that food, can go through breast milk into the baby's stomach or body. But in most cases, we find that if the food allergy is a mild food allergy, the mother can actually sometimes continue eating it, and it becomes a way of gradually
Tolerance.
desensitizing the baby eventually from it. So there are a lot of critical decisions that we as clinicians have to take based on the history that the mother has come with the baby, and what the baby is going through, and what the baby's tests have shown, to really guide the mother about breastfeeding. We are very big proponents of breastfeeding. They have way more advantages than disadvantages. So I have never ever in my entire career told a mother that just because their baby has a food allergy, that the mother should stop breastfeeding because she's eating that food. I would much rather she eat it and pass it on to the baby than stop breastfeeding. There are too many benefits to it that we do not want to miss for that baby.
Interesting, and I agree with you 100% on the breastfeeding part. That it confers way more benefits than the risk that we would see with an allergy. But in short, if there's no history indicating both for the mother and the baby, there's nothing really that we need to avoid during the pregnancy and the breastfeeding phase, right?
Absolutely. Other than the unhealthy foods that I would call, so a lot of junk food and sweets and candies and chocolates, which cause inflammation in the mother's body.
Right.
And that inflammation can actually affect the baby's developing immune system and possibly all other systems in that baby's body. So the mother needs to take great care with their diet, but not necessarily for allergenic foods, more for inflammatory foods.
Right. And is infant colic related to food allergies or intolerances for that matter?
So I think that this is again a very interesting topic. Infant colic, to understand first, is believed to be a multifactorial disease.
Okay.
Right from how stressed and anxious the mother is, to how stressed and anxious the baby is, to what the familial circumstances are around the baby, to what kind of microbiome the baby has, to having infections in the gut, and many other things. Gut infantile colic is a very complex topic. If we look at the amount of contribution that a cow's milk protein allergy can do to infantile colic, it's very, very tiny.
Okay.
but it is relevant.
Hmm.
So if all the routine measures have been done with that mother-child family as a unit that a pediatrician would routinely do to manage infantile colic, and the child continues to have problems, or in the situation that both parents or one parent is highly allergic by nature, or they have siblings who have bad allergies, or the baby themselves is having, let's say, wheezing, or having nasal allergies, or having atopic dermatitis, which is eczema, there the search for a cow's milk protein allergy or whatever that baby is consuming in their diet at that point to see if it has a relation with their food, with their infantile colic, makes sense. But it's never the first thing that we look at in general, unless the history is very, very strong. And again, if we do find a problem, we sometimes just do a trial of what is called a hypoallergenic milk formula. This hypoallergenic milk formula can be something called an extensively hydrolyzed milk
Right.
formula. And if the child does well on it, even without testing for the cow's milk protein allergy, we can leave the baby on it for a few
Right.
weeks, months, then do a retrial of milk. And if it gets therapeutically proven that it's helping, then we continue it for till it's required. Generally, it's not a very long requirement. It may be a couple of weeks or months is all it has to be done for.
So that means if there is colic in the room, we need to address other things like the microbiome, maybe the mother's diet, maybe her stress levels. I read a very interesting research where it was mentioned that stress affects the milk composition.
Absolutely does. And
And
there's
in terms of the macronutrients, like the
true.
carbohydrate and the fat composition of the milk gets affected by
True,
stress.
true. And you bring up again a very important point, because stress and allergy has been my fascination and field for many, many years. And the stress alters the baby's immune system, the mother's stress. We call
Right.
it perceived stress. Not even necessarily the mother may be actually having problems, but her perception of stress.
Right.
If it's a very high perceived stress scale, that child has higher risk of developing atopic dermatitis, which is allergic eczema, high risk of developing wheezing in the first year of
Right.
life. So that shows that the mother's, what I would call mental status, emotional status, psychoneurostatus, actually affects how the baby's immune system functions. So yes, this is a very, very relevant and important topic, and we certainly deal with it in our clinic in more than one way than just telling them lower your stress, because that's easy to say and much more difficult to do.
It's a silent killer, but unfortunately, you can't even measure it. It's
True.
not tangible. And at the end of the day, let's not forget that we use steroids to control inflammation, which is actually anti-stress, right? We're
Correct.
trying to reduce inflammation by
Correct.
using. So obviously, it affects the immune system directly.
Correct.
So, Dr. Roy, this brings us to our next topic, which is the early introduction of allergenic, so-called allergenic foods. When the child is weaning off breast milk, and I'm typically talking about honey. I'm talking about eggs, whole eggs, egg whites. I'm talking about milk. I'm talking about wheat. I'm talking about fish. So, can you tell us about the yes and the no's of these foods, whether we should be giving them or we shouldn't be? As far as I know, and research also talks about introducing them early, especially if there's no history, because that helps them to develop tolerance, as you mentioned earlier. So, can you tell us from your experience about these foods?
So again, when I initially became a pediatrician in America, at that time there is something called the Red Book, and the American Academy of Pediatrics releases that, which has additional information, and their nutrition and dietetics books, which they release for food management. We used to be told that for high risk infants, so babies who have a high risk of developing allergies, the baby should be not given milk formulas till the first year of life, no egg till 2 years of age, and no seafood or peanuts and tree nuts till 3 years of age.
Right.
Now, this has completely been debunked, completely. Now we realize that avoiding actually increases their chance of developing allergies when we try to introduce it later. Because interestingly, what happens is, in the entire family, if someone is eating it and they happen to touch the child, kiss the child, come in contact with the child, Now the food allergen in very tiny quantities goes through the skin barrier
Right.
and has a higher chance of giving allergy because it's a dose response. You put nanograms and picograms of a protein into the body may fight it like an enemy.
Right.
But you put milligrams of the food or grams of the food through your mouth, your digestive system is your best tolerance system. So the latest data says that somewhere between 4 months and 11 months is the prime time for introducing all kinds of foods into a baby's diet. And this was very elegantly done in a study where they took high risk babies, so the ones who are at high risk of developing allergies, and started giving them peanut from 4 to 6 months of age.
Right.
And they took another group whom they did not give peanuts. And they found that by the time these kids were a year or 2 years old, the chance of developing a peanut allergy was much higher in the group that had not been given peanuts in the early phase of life. Now look at this, because I have an immense fascination with ancient Indian dietary traditions.
Right.
I truly believe that Indian Rishi Munis, saints were very, very, very divinely blessed people with amazing research. And when we talk about Annaprashan,
Right.
or what I'm a Bengali, so we say Mukhir Bhat, it always used to occur around 6 months of age.
Right.
And that's where we would introduce rice, milk, maybe some ghee, maybe some jaggery into the baby's mouth and begin the process of weaning.
Right.
And subsequently would come the different grains, the different vegetables and fruits, and then the nuts and all the other factors that go with it.
Right.
So even back in ancient India, our culture and tradition knew that the right time to introduce these foods was somewhere around 6 months.
Right.
Now modern medical data is reconfirming that for us with double-blind, placebo-controlled trials and food challenges. So I think we have a lot to learn and gain from what has been our tradition and culture. But the current belief is that unless the child has an allergic reaction to a food, then you have to avoid it. Just because a skin test or a blood test came positive, that is not avoidance. You have to look at the clinical relevance, and when you just introduce them sequentially, going from the ones that you would naturally and traditionally do to the ones that you're most worried about. So whether it is a peanut, a fish, a shellfish, a tree nut, pretty much everything would get introduced by the time the child was 1 year old. This is what I knew growing up.
Right.
And I think that is now being accepted by modern science. So no special avoidance just to try to avoid allergies doesn't work.
I think what I'm gathering from this conversation is the avoidance is creating more trouble than the exposure.
It absolutely is, because you're now allowing a big window of time where tiny amounts of that food from a friend, a relative, a parent getting into the child's body may cause more havoc than actually eating it.
Because the kid is anyways getting exposed to it in some form, right? What about honey? Is it also recommended for babies before 1 year of age?
So it's actually not. And the reason is more about the risk of infections, because sometimes honey can carry certain bacterial toxins, if I may call it, which can cause infections, and those infections can get very serious and even be life-threatening, like a severe gastroenteritis, even going to the point of septic kind of pictures.
Really?
So typically honey is not something that at least Western science recommends or modern science recommends to be given to a baby before 1 year of age. Now this has a lot to do with how the honey is derived, stored, saved, purified, given. So, but as a general rule, we tell parents that it's better off that you give jaggery, which is the healthier form. I would say sugar, but I don't want to say that, because refined sugar is not good for anyone. Not you, not me, not for a baby either.
The amount matters.
The amount matters. I completely agree. But where we have a choice, we would want to go with a natural form, but not honey.
Right. So, Dr. Roy, wheat is the hottest topic these days. And there's so much confusion around because there are so many different sub-conditions, right, when we talk about wheat. So, we have wheat allergy, which is a true allergy. Then we have, celiac disease, which is an autoimmune kind of a condition. And then we also have the gluten sensitivity, which is non-celiac. So, I know these are all very complex terms, but I just want you to simplify each one of them so that our audience understands how to differentiate between these three.
Sure. We'll start with wheat allergy. Wheat allergy, which we would then expect to be a specific IgE that is developed towards one of the key proteins of wheat.
Right.
Let's say it's gliadin, or it is omega 5 gliadin, or it's
Right.
any of the other proteins
Right.
in wheat. In this situation, we would expect the person to have either rashes or itching or swelling or nausea, vomiting, diarrhea, or the classic allergy symptoms. And this would be followed by a positive allergy skin test or a specific IG or CRD test that confirms it. There are some very specific forms in which wheat allergy comes, where only if a person exercises after consuming wheat within 3 to 4 hours, or they take a painkiller, or they have alcohol, they can develop a severe allergic reaction to wheat. Whereas if they ate wheat just by itself, they would have nothing.
Is this the exercise-induced anaphylaxis that I've heard about?
Exactly. So it's called wheat-dependent exercise-induced anaphylaxis. Though exercise is a misnomer here, because it can also be alcohol, it can also be painkillers,
Right.
it can also be other things. But this is a classic example of a wheat allergy, and a baby getting eczema, rashes, swelling, itching due to it is another example. So in these situations, you have a clear-cut test that can help you.
So this is a pure food allergy.
This is a pure food allergy. Now we come to celiac disease, which you rightly said is an autoimmune response, where the same gliadin and certain other proteins in wheat, the immune system makes more of an IgA, that is our secretory antibody,
Right.
and an IgG against it to certain proteins or enzymes. And as a result of this, the person gets the classic symptoms of abdominal pain, nausea, diarrhea. They can even get sometimes blood in stools. The symptoms are very, very different than a classic food allergy. And here there are excellent blood tests that are available. We do something called a tissue transglutaminase.
Yes.
There's an anti-gliadin antibodies, there's an anti-endomysial antibody.
Yes.
There are several tests available, and there is genetic testing. So we can do something called an HLA testing and confirm that this is celiac disease.
Right.
It requires complete elimination of gluten from the diet in any form. So it's not just wheat, then you're talking about rye, barley, and other sources of gluten also have to be avoided. And even contaminated foods can create a lot of symptoms. And there, once you do that gluten avoidance, the person can have a completely normal life with no symptoms. So that's a very selective condition, an autoimmune condition. We have once in a while seen this also go into remission, but generally can be a lifelong condition. When we come to non-celiac gluten sensitivity, now this is a very, very gray zone, okay?
This is the biggest group.
And in this group, it's not just gliadin, but there can be other proteins that a person's body processes differently, if I may say it. Again, whether there are cell-mediated immune responses, what we call T-cell mediated responses, or there are immune complex reactions, very hard because there's no test to identify these things, or even if it is not due to an allergy, not due to a hypersensitivity, right word, not really an allergy. But as you can probably comment on this, the role of FODMAPs comes into this, because these fructo-oligo-di-monosaccharides that are there in wheat can sometimes be giving reactions in the body which are not an allergic reaction. And similarly, there are other what we would call non-immune chemical-based, or you can call them tissue-based responses due to leaky gut or other phenomenon, because of which, it's actually been shown that gliadin can increase the chance of not completely digested proteins leaking into the bloodstream. Now, this can then give reaction to other problems that a person has, increases their zonulin levels, which then mean that they have bigger gaps at a microscopic level in their gut. And so I think the non-celiac gluten sensitivity is a very broad disease, too many things that are unknown, no test to diagnose it, and elimination and reintroduction happens to be the only way that we can really get to the bottom of it. I hope that kind of clarifies, and I would love to hear your experiences on this also, because I'm sure you get a lot of people with this issue.
So I'm just going to talk about the last bit because, again, I haven't really dealt with the true wheat allergy yet, and neither have I dealt with celiac disease. But I think the sensitivity, the gluten sensitivity, as you rightly said, is diagnosed by exclusion. When you know you don't have the other two conditions, and you probably have a gluten sensitivity. Yes, in the clinic, for me, what I do is I maintain diaries and we do an elimination and reintroduction. And I mean, of course, there's a bias involved, but most of the times I see that it gets cleared up. So then I just leave it to them and I say, okay, maybe you can do it once in a while and then observe what happens. But one interesting thing which I really want to talk about is in terms of the gut. You spoke about leaky gut and gliadin increasing the zonulin levels and all of that. But the point is that if you already have an inflamed gut, everything kind of leaks out.
Very true.
So sometimes you may react to certain foods, although you are not intolerant to those foods or you don't have an allergy, but it's only because your gut is not functioning the way it's supposed to. Like you said, it's your first barrier, but it's not working fine. So it's allowing everything to come out, and then your body is getting hyper reactive to each and everything. So for me, as a dietitian, I would like to first clean up that part, get the gut strong, get it stable, and then try whether these foods actually are, causing trouble or not. So there's no point in unnecessarily eliminating if it isn't. Most of the times, just by doing the diary and cleaning up their diet, after a month, they have no symptoms to the same foods that they thought they were reacting to. So this is how I do it.
I completely agree, and you bring up a very important point. Even as allergists, we have to do food diaries sometimes with our patients to narrow down the relevance of maybe a test that they did and came to us, which we spoke about,
Right.
Or even to find out what their triggers are. And I think that when we get to track, because in my practice I see both kids and adults and a wide range of diseases, I think food diaries are extremely helpful. And you're absolutely right. When you eliminate some of the key, what I would call inflammatory foods that a person is consuming,
Right.
and you let their gut heal, and maybe along with it, you improve their microbiome by giving them the right kind of probiotic supplements
Right.
and other things, which again I think should be done with clinical guidance. I
Yes.
know a lot of people are doing it on their own these days, but I believe that not every probiotic is created equal, and
Sure.
there are specific ones that help specifically in certain situations. But when you do that and then you reintroduce the food, sometimes they start tolerating the things that they were not being able to have before. So I think it makes a lot of sense to maintain these diaries and do it exactly the way you said.
And again, as we come to the topic of overdiagnosis and doing these irrelevant tests, now we also have the stool microbiome test. Then we also have the zonulin test to check whether you have a leaky gut. Whereas research has already said that these are irrelevant and they're not even FDA approved. So I see like this whole bunch of tests being done, and people are getting more confused because of those tests. And I feel like allergies are not increasing because of the exposure, but more because of testing more than required.
You bring up a very, very important point, and something that I speak about every time I train doctors at the various centers across India that I teach allergists who are in training, and even other doctors. I speak to wide groups of people. I always tell them that there are a lot of what I call spurious tests available in India right now, unfortunately. They're available for 4,000, 5,000, 8,000, and they'll tell you we'll do these 150 foods that we can test you for. And people come to us with these reports and they're completely useless. Means they're testing for cement allergy and allergies to very, very irrelevant things,
Right.
20 drugs that they've tested. And I tell them this is not even a report that I can look at.
Right.
Forget interpreting.
Hmm.
And you're right, people just randomly go out and do this. Some are told by their family doctor or someone else or a friend to do it, and others do it because they were told, they just read about it on the internet. And same with the intolerance tests. When you look at the real incidence of food allergies in India, Shweta, you'll be very interested to know that all the very good studies where they've actually done a correlation of the test with a challenge, the incidence of food allergies in India is less than 1 or 2%.
Wow.
True food allergies, okay, confirmed with a challenge. Now, that does not mean that it is really that less. It may be more because you need more extensive and big studies.
Sure.
But in whatever has been done, the percentage seems to be lower than in the West. And I think that has to do a lot with the variety of diet that we have with the fermented foods and everything else
Sure.
that protect us. But you're right that, when I look at other tests that are very confusing, there are tests where people do kinesiology tests. and those are called food allergy tests. Now, if you told an allergist that this is a food allergy test, they would say this is an unproven technique because you're not measuring IgE, you're measuring energy. So it should be called a food energy test, not a food allergy test. And really, reproducibility is very hard. So when we have done in the West and even in the US research on kinesiology or pulse variability, people
Right.
use all kinds of things. There are
Right.
different electromagnetic testing that they do for food
Really?
allergies. Yeah, there's absolutely no clinical correlation when we run it through what we would call a classic research protocol. And hence, I always tell people take these things with a pinch of salt. Some swear by it, some get no benefit and come to us. The truth lies out there, and I'm not saying one way or the other, but I always would suggest someone to really get proper clinician and medical guidance before they do any kind of test and spend thousands of rupees and sometimes even lakhs of rupees desensitizing through some of these processes before really understanding whether they have a food allergy or not.
I agree. Coming to the topic of the gut, right? I really want to bring up IBS because, again, it's very loosely used and everybody has a gut issue today. Everybody has a gut issue today. So, how do we differentiate whether this is really a food causing a gut issue, whether it's just an inflamed gut, or it's just a hyperactive nervous system? What is happening?
So I think that, again, dialing back to what we spoke about a little earlier as stress, okay? Now, people think stress is just mental, emotional, psychological stress. We also have physical stressors, long hours of working, not sleeping well, which affects our immune system and our gut pretty negatively. You can have many other forms of stress besides this also. Just the food that we eat, as you said, affecting the type of bacteria we have in our intestines is a form of internal stress which our gut-brain axis very sensitively measures and feels.
Correct.
Now, when you have a person going through a lot of stress for different reasons, internal and external, and they start getting these symptoms, it's an imbalance in what we call the gut neuromodulation. Okay, so they get dysmotility, they get dysbiosis. Dysmotility means wrong movement of the intestines. You eat and you have to run to the restroom. Okay, you eat and you get all gurgly and bloaty and gassy. And you can also have, as I said, the peristalsis gets affected, the motility of the gut. The nerves in the gut are all stimulated and activated and hyperactive. Unfortunately for IBS, even after so many years, we don't have a medical test for it. It is still a clinical diagnosis. It's a diagnosis of elimination, where you have eliminated the possibility of an infection, someone having gastroesophageal reflux, someone having other diseases, SIBO, which would be a bacterial overgrowth. In some of these cases, the microbiome test can be beneficial, but it's very confusing. But you do have something like a hydrogen breath test, and you have some other tests that can help you, which are medically tested and aligned with what we do as doctors and gastroenterologists do, which can be very helpful. But I always tell my patients that food allergy connecting with IBS is something that is still very, very early in its research. There are some studies that say that food allergies can trigger IBS. There are others that say there's no connection. I'm somewhere in the middle. I'm on the fence with it. So if I really feel the need, I will evaluate the food allergy angle in a person who's done everything else right. And in some cases, there is no connection and relevance. We actually have to work with their, what I call mind, body, spirit axis, along with, as you would do, put them on an anti-inflammatory diet, get all the bad stuff out of their diet, and then work with them to try to get their mind, body, and gut nervous system calmer so that they can not have the IBS then. So as we've spoken, we all believe in diet and nutrition. Food is the first and last medicine, hence we are both sitting here. And I think the right choices with the right guidance is the key.
That's the reason I don't have many people to send you to once you've come to me.
Very true, and I'm happy for that, because if food allergies are actually rare, then let it be so. The unfortunate part is India is tracking the West when it comes to the growth in allergies. So in the 50s and 60s, food allergies were not common in US and UK. They became common after that. And today their incidence of food allergies is anywhere between 5% to 10%. Adults maybe 3 to 4%, pediatrics up to 10%, okay, or 5%.
Right.
I think that India is going that way because of the westernization of our diet and lifestyle and all the
Correct.
stressors that are
Yeah.
there and all the pollutants and chemicals. And that's why when I counsel mothers and they come to me saying, my one child has food allergies, how do I prevent the next one? I said, the work begins with you.
Correct.
The work begins with you during pregnancy and everything that you do.
Right.
And we get a lot of cases like that we counsel and train and work on, both with the mind-body aspect. And it makes a big difference to the outcomes. So I think you're right. I'm glad you don't have patients to send to me now, but what I try to, and the reason why we do podcasts like this is because I know this is increasing and there's going to be more and more people who are going to be facing these issues in the near future. If it's not a food allergy, it's a food hypersensitivity. If it's not a food hypersensitivity, then it's a food intolerance. But we all know that it is growing.
Right. Thank you so much, Dr. Roy, for taking out time and doing this episode with me. You really helped us navigate through this complex world of allergies, and it was an eye opening interaction for me as a dietitian because I learned so much. And I look forward to using this platform and doing more such interactions with you where you can keep our audience informed and educated.
Thank you very much, Shwetha, for having me on your podcast and on this session with you. I think there's a lot of myths and errors that are going on, which hopefully people listening to this will be able to avoid and be more safe,
Right.
get the right kind of testing, treatment, and follow up so that they can have a healthy, happy life. And it's very, very important that what you and your team of nutritionists, psychologists all are doing in these case scenarios. So thank you for what you all do and thank you for having me.
Thank you. Thanks for tuning in. If you found this episode useful, please share it forward with a friend or family member who might need this info too. For more science-backed nutrition tips, follow me on Instagram at the rate Shwetha_Bhatia or visit mindyourfitness.in. And don't forget to subscribe to the YouTube channel. Until then, stay healthy, stay informed.